Weekly Center for Digital Health seminar series. For those who don't know me or who are joining us for the first time, I am Megan Ranney. I am an emergency physician, director of the Brown Lifespan Center for Digital Health, and Associate Dean of Strategy and Innovation at the School of Public Health. The mission of our seminar series at the Center for Digital Health is to really both bring together folks from across Brown and our affiliated hospital systems, and to create opportunities for collaboration and education with people who are doing great work around digital health innovation in the external world. And as you guys know, we'll kind of switch back and forth within our seminar series between internal presentations from trainees and researchers and external presentations from some of the leaders in this world across the country and across the globe. And so today, on that external presentation theme, I am absolutely delighted to welcome David Grandy. David was first introduced to me by a former Brown graduate, Anand Shah, who's an emergency physician who did residency here at Brown, and who now works at Kaiser with David. David's been working in healthcare for more than 20 years in a wide variety of health systems leadership positions, including for Google, GE, the AMA, the American Hospital Association, and now he is Vice President of Transformation at Kaiser Permanente, where he works on various projects aimed at transforming our delivery system. Most recently, and one of the ways that he and I have connected is that he's led design efforts for KP's COVID-19 alternative PPE production initiative and home prevention program. He's also co-leading Governor Newsom's statewide testing task force. He is a true leader at thinking through how we can think outside the box in terms of how we create change within healthcare. And so I'm super excited to welcome him today to talk to us about his work and his role, and about the role of design thinking and public-private partnerships in changing the way we deliver care. So without further ado, David, I'll hand it over to you. I will say we normally talk for around 40-ish minutes, 45, and then give a little time for Q&A at the end. But if your talk is 30 minutes, I'm sure we'll have lots of questions from the audience as well. So take it away. Thank you for joining us.
Okay, sounds good. Thank you very much. Thanks, Dr. Ranney, for that very generous introduction. Good morning from the San Francisco Bay Area. Good afternoon to all of you. Appreciate the time to be here. This is a bit of the roadmap that I thought we would cover. I want to set a little bit of context about kind of our organization and some of the sort of constraints of our organization, how it is that we think about innovation, and then talk a bit about design and this intersection of design and business, which is predominantly how we think about innovation and the types of problems or approaches to problems that we take at KP. I don't want to spend a lot of time on organizational context. I think most folks are sort of at least generally familiar with Kaiser Permanente. But I do want to make 2 points about our organization, because I think it's helpful to understand how it is that we go about innovation when you understand something about the organizational context. I was actually at a conference, a virtual conference this week, listening to one of KP's leaders talk about our work, and noticed in the chat that somebody had posted, "It must be so easy for you all at KP to get things done when you have complete alignment across kind of your hospital environment, your physician providers, and the payer." And certainly it's the case that our business model, being a fully integrated system with a payer component and a provider component, allows us to do things and invest in things, particularly upstream innovation, addressing the social context of disease as an example. It allows us to do that in ways that maybe other organizations can't. Though certainly we have to abide by the same constraints of government payers, Medicaid, Medicare Advantage, and so forth. So that's the upside. There are, though, some inherent challenges, and one of those that I don't think most people know, unless you can kind of peek behind the curtain of KP, is that we are actually 9 different corporate entities that are all sort of bound together by an operating agreement. So particularly with our physician partners, there is no one voice. There are really 8 separate organizations that we have to partner with at any given time. And so in any instance where we're thinking about innovation and scaling that across our organization, there are some inherent challenges. So even though we do have those connections between the payer side and the provider side, it's still a very complex organization to navigate. And it really takes a lot of social and political capital in order to get things done. The part of the organization that I work in is called the Office of Transformation. This is a group that was founded by our former CEO, Bernard Tyson. And really the mandate of the group is to drive structural change that adds new types of value to our organization, and in so doing, perhaps inspires others. We have this mantra that we want to be independent and connected, and that is independent to think and explore freely and not be bound by the constraint of the organization or the status quo. We often talk about, at Kaiser Permanente, we are 98% an operating company. And that means there is this incredible gravitational pull to operating and doing the things that we know how to do, efficiency, day in and day out. Oh boy. Well, that's not going to be good, is it?
Never a dull moment, David.
I'll tell you what. All right. Well, let's see here.
I think that if there's a fire alarm going off as a healthcare provider, I should probably tell you to pause. We can
pause.
Yeah.
Right here in the moment. I'm so sorry.
Oh, it's so not your fault. Presumably it wasn't you that left a piece of toast in the toaster.
You guys have been a full-on tour of this was not a planned part. You can see the lovely 2-bedroom townhome setup that we have.
I love it. Things we all miss by not being in the Bay Area.
Oh my goodness.
This is where we see how strong your Wi-Fi is, right?
This is exactly right. Okay. All right, let's do a quick check. Can you guys hear me okay? Can you see me okay? So let me just go back here.
And David, I will also say, if you have to do with your fire alarm, we can reschedule. You know, real life takes priority over virtual talks.
Yeah, I appreciate that. If there's any imminent danger here, I will certainly keep life safety in mind. Safety first, as we say.
Yeah, I got to be a good ER doc here and make sure that you're.
Yeah, thanks. I see no visible signs of danger at the moment. I have at least 2 escape routes from the roof, so we'll just go with that for now.
All right, go for it then.
My apologies on that front. So I think I was talking about our former CEO and sort of the sort of organizing philosophy of the group. Are you guys able to see the slides still? I went from a 2
No, I would say reshare them probably.
Okay, let's give this a shot. How about now? Do you have them? All right.
No. Now we see it.
Yes.
It is not in presentation mode, but we see the slides.
Okay, if it's okay, we'll just go with this. And
totally fine.
We'll kind of wing it. So this particular slide gives you a sense of our portfolio. In the pre-COVID days, really a dual focus on social innovation and growth or new value for the organization. On the social innovation side, working on issues like food insecurity, housing instability, the prevention of childhood trauma, looking at the digital divide, which I think would be of particular interest to this group as we start to move our organization towards a digital first enterprise. What are then the implications around access for communities that can't engage with us in primarily digital ways. Growth, looking at a project or platform that I'll talk about in a bit called Focus Home. And then sort of as mentioned in the onset, in COVID times, we've really switched a lot of our portfolio's focus to all things COVID, whether that be testing or in recent days, looking at the human factors of vaccination. So that's a little bit about the group and sort of where we fit in organizational context. I want to spend just a minute talking about this idea of design. And I just sort of want to level set around that a bit. You know, I'm a hospital operator by background. I started my career running hospitals, and it, you know, I think that experience in a lot of ways formed and shaped my perspective on design, which may be an odd thing to say. But in those days in particular, it was always the case that, you know, we were faced with what seemed like problems without precedent. And for a long time in my career, I was searching for a set of tools or methods or mindsets and approach to be able to tackle those problems that didn't have precedent and to do them in ways that were not only effective, but also repeatable. And I think for a long time in my life, I had this sense that design, I had this incorrect sense that design was predominantly about aesthetic, that it was about buildings and interiors and color palettes and furniture selection and this kind of thing. And what I came to learn over time was that the way that designers go about their work, which is to essentially take a problem, to disaggregate it, to look at its component parts, to understand the inherent needs that are attempting to be solved, and to then reassemble all of those components into something new, that there was a way of doing that that was repeatable. There were tools and methods that could get us to an effective outcome over and over again. And that, in fact, designers, as they go about their business, as they sort of think about problems, they're thinking about the same kinds of things that I, as a hospital operator, was considering. So function and experience and quality and safety and cost. And so I started to think, you know, maybe there's actually something to taking the tools and methods of design and incorporating them into a practice of design-based innovation. And that really, in many respects, became my mission. You know, in a lot of ways, the current healthcare system, even today, resembles what it did 50 or 100 years ago, largely based on a come-to-us model where acute episodic illness carries the day. And in fact, I think we all know that in many respects, we have to flip that system inside out and find ways to actually meet people where they are. And when you start to come to terms with that mindset, you start to realize that the traditional healthcare system is full of a myriad of design problems, right? This is a design problem. This is a design problem. This is a very clear design problem relevant to digital health. This is a design problem, how it is that we look at the financial side of the business. This is a clear clear design problem with a clinical implication. This is a different kind of design problem for health and healthcare. This is a design problem. Even pressing today, getting vaccines in arms is a design problem. So these are the kinds of things that, again, in our practice, we tackle on a day-to-day basis. But what's also important to understand is that we're not just thinking about sort of the design side of things, we're also simultaneously thinking about the business side. Kaiser Permanente, which was founded by two individuals, Henry J. Kaiser, an industrialist who produced ships during World War II, and Sidney Garfield, a physician, sort of combined to bring together a business model and a way to meet human need, in this case, healthcare needs, in a preventative way that fundamentally transformed the industry. And so for us, we're always thinking about this sort of combination of human need and business need. And so when we say design, as IBM said, in the 1960s, for us, good design is just good business. It's part of the DNA of the organization. And as I've suggested, as we go about our work, we're interrogating problems both in terms of human need, that's the design side of the equation, and business need simultaneously. So I'll use just a quick non-healthcare example to maybe illustrate how it is that we think about solutions that simultaneously meet the needs of humans and the needs of business. And that is to talk for a minute about car insurance. So insurance is obviously a world that we live in. Auto insurance, a $200 billion industry in the US. I don't know if anybody's been in the market for insurance of late, but when you go and actually try and purchase auto insurance, it is a really complicated thing to do from an end user perspective. It's hard to understand differences in plans and policies and cost trade-offs, what's included, what isn't. All of that is pretty opaque to an end user. So a number of years ago, enter Progressive Auto Insurance, who was the number 3 or 4 player in the market behind State Farm and Progressive, State Farm and Allstate, excuse me. And Progressive introduced this really interesting digital innovation that if any of you are Progressive customers, you've probably used, and that was the price checker, the price finder, right? And I think most of you probably have seen Flo pitch this at one point or the other. The whole notion is you can go online and enter some basic information and the price checker will come back and it will compare Progressive's price for you with their competitors' prices. So suddenly all of that opaqueness, the parts of the business that were invisible to an end user, those parts were suddenly very tangible. And I, as a consumer, could make an informed decision, right? And Progressive had this great pitch, which was, you know, sometimes we're the most competitive and sometimes we're not. And we'll be transparent about that with you, right? So that's the human side of the equation. Here's the business side of the equation that doesn't get talked about as much. And that is in any insurance business, profit or the economic model is fundamentally driven by loss ratio, right? And very simply, that is, how can we extend the gap between premiums, what it is that we take in revenue, and claims, what it is that we pay out in losses. And any of you would instantly recognize there are sort of 2 ways to do this. The first, we increase volume, we increase our premiums by driving more people into the business. Well, the price comparison tool was that driver for them. The second side of that is we reduce claims. In this instance, we push lousy drivers somewhere else. And guess what? If I go to the price checker and I enter this kind of basic information in my driving history, if I'm not such a great driver, their algorithm will artificially inflate Progressive's price and make their competitors' prices look better. And so simultaneously with this one innovation, they are solving both human and business need. And so philosophically, that is effectively how we approach our work. Now we do that in the context of what we sort of refer to and think of as socio-technical systems. So we work in the realm of systems design. And of course, in any design process, there are a lot of different scales in which you can work. And in many instances, those scales sort of layer on top of each other. So from UI design, which is a very common space in digital health, all the way up to complex systems design, which is the space, as I've mentioned, that we really work in. So as we begin to go about the work, this is sort of the method that we use. We start by trying to deeply understand and interrogate problems, both from a human perspective, that's the socio side, thinking about function and psychology and choice and trade-offs, how it is that the human mind processes information, as well as then from the commercial, scientific, operational, or technical side of a problem. So if we take something like vaccination or testing as our example, you know, one of the arguments that we've made in our own organization is that for a lot of good reasons, we've spent a good amount of time really focused on the technical side of vaccination. So the science had to be right, the logistics had to be right. And now what we start to hear about is getting shots in arms. Fundamentally, the socio side or the human side of that problem has some gaps. And so we're doing a lot of work to really address how it is that we communicate around vaccine and vaccination, the messaging, the channels, the messengers, what the service experience is like when people show up either to a pharmacy or a clinic or even a mass vaccination site, all of which have a different set of inherent problems. So again, when we're thinking about things from a system perspective, it's always about both sides of that equation. And then we move into kind of the design aspect of things, thinking about multiple time horizons. If we want to envision a future that's 5 or 7 years out, then what are the immediate steps that we might take, smaller steps, incremental in service of that longer term vision. And then we begin to apply those things through a combination of tools like human-centered design, platform thinking, and in particular systems mapping. Any of you who are familiar with systems design or systems thinking will sort of instantly recognize the network or nodal diagram here in this slide. This is a tool and an approach that we always use in the work. There's some animation to this that I won't show you given this sort of limitation here of time. But what you're looking at is sort of a high level system map that we did around testing in the early days of our work with the California Task Force. And this was to look at all of these different value loops, as they're called. What are the inputs to those? What are the outputs to those? How does one value loop feed information or product or an outcome or human capital or technology, whatever that is, to another? We begin to look at, are there places where there are bottlenecks? There's a constraint in the system that we need to solve for. Is there a human component where we've made an assumption that humans will actually use the solution that we've put forward in some way, that if somehow that assumption turns out to be incorrect, if we haven't solved for the human dynamic, the system itself begins to fall apart. And it was really from that combination of sort of deeply understanding the problem, looking at both the human and commercial aspects of testing, looking at the system as it was designed in total, and identifying some of those barriers or pain points, that we can begin to think of system level solutions that effectively operate at different layers. Some of those things are foundational. It's sort of a direct to end user, from a business or government to an individual person, looking across communities, or even looking across entire populations. And so that effectively has been kind of our approach. So I want to talk very quickly then, now that you've got some context about how it is that we define design and this sort of interface between design and business, I want to talk a little bit about some of the lessons that we've learned and apply in our work, or that we've learned from sort of working in this space. And there's sort of 5 key lessons that I think we come back to time and time again. And the first is this idea that we really want to fall in love with problems, at least initially. I think so often what we see, even in ourselves, is that we come to the table with a set of assumptions about what the solution should be. We come with these mindsets of, we think that we know how to solve the problem before we even understand the problem deeply. And so we go through sort of a whole series of exercises, sort of a mental palate cleanser, if you will, to get what we think are those solutions out on the table quickly, because typically they're inherently wrong. I love this quote from Ed Catmull, one of the animators and founders at Pixar, who really says there are all sorts of problems inherent in business. We devote a lot of time to seeking out what those problems are. So it's a problem first mentality. But one of the things that's sort of important as we do our work is this idea that the way that others frame a problem, or whatever that initial problem is, that we don't accept that your framing of the problem isn't necessarily my framing of the problem. So there's this great example in architecture of a primary school in the UK that was built in the middle 1950s, early 1960s, and had these ridiculously narrow hallways. And the administrators of the school had noticed that at the time that students would go from class to class, when the bell would ring and students would go from one place to the next, that you'd have all of these behavioral problems. When the students would interact in hallways. You put a lot of hormonal teenagers together in a tightly enclosed space and you might, have a little bit of conflict, it turns out. And so they approached a set of architects and said, look, we need a new school and we need better hallways and better facilities and this kind of thing. And the architects, to their credit, really interrogated that problem and said, your framing presupposes a solution, and that is that the built environment is the right way to fundamentally solve a behavior problem. And as they sort of really looked at, what are we trying to accomplish? And is there a different way of thinking about the problem? What they really discovered was that to change behavior in this instance, really the better solution was to change when the bell rang for different classes so that you weren't putting an entire cohort of students into this space all at once. And so it's sort of a brilliant example of how the reframe of the problem itself actually makes some difference. And I use here in sort of I think a timely example, one of the things that we're talking about in our organization is this notion that vaccine hesitancy, which is a prominent and predominant narrative in the popular media, actually isn't one thing. Certainly it's the case that for certain communities, particularly Black and African American communities, there are some very justifiable reasons to be hesitant. When you look back at some of the really unethical and egregious things that were done in a federally operated program, Tuskegee, the Tuskegee experiment, there's absolutely good reason to be hesitant. Interestingly, in some of our research, as we've interfaced and done deep ethnographic inquiry with members of that community, we weren't hearing hesitancy as that predominant narrative. And in fact, as we studied the term and use of hesitancy in Black media, we really didn't find it at all until months after we were hearing about hesitancy in the popular media. And in fact, I think as probably many of you know in your day-to-day work, this idea of hesitancy really is not monolithic. There are any number of dimensions to it, whether it's people who are afraid of needles, or they think that the vaccine was produced too quickly, or they have political reasons, or we could go on. But our ability to actually frame hesitancy as a multi-dimensional problem starts to unlock for us different ways of thinking about how to tailor solutions to particular audiences that have very specific types of needs. So after we fall in love with problems and we start to envision what it is that kind of a future state might look like, one of the keys for us is to make sure that we're not designing solutions that have what we would call dead ends. And I'll use the example here of some work that we did early on in our organization with natural language interface, with Alexa, as well as with chatbots. So I think like many organizations in the early days of COVID, our call centers were being overrun with people who had relatively basic questions. And so there was this thought that we could use a natural language interface or alternatively an online chatbot to reduce call volume. And in a lot of respects, we were able to do that very, very successfully for the types of questions that people were asking. And even now, when people have questions about things like vaccine eligibility or the location of vaccination sites, hours of operation, this kind of thing, I think these tools are very effective. The leap that we and I think other organizations started to make was, okay, how can we use this technology for other things like triage, as an example? Can we adopt the Barton Schmidt protocols, a kind of basic decision tree for this type of channel, this type of an interaction? And like what we've tried to do as we've approached that work is to say, yes, certainly there's a good use case for that, but let's really think through what that end-to-end experience needs to be.
it's not just that we do triage, that I can ask Alexa some questions or give some symptoms, and then ultimately I have to pick up a phone to resolve my problem. Really, if we're going to create a system that doesn't have dead ends, this solution has to not only triage me, it has to be interfaced with our electronic health record to know that I have asthma. So the wheezing or shortness of breath that I have is clinically different in presentation than it is for somebody who doesn't have asthma. To know in that instance that I need to actually go to urgent care today and not wait for an appointment tomorrow, to tell me where the closest Kaiser Permanente urgent care is to me, to push that address to my smartphone, to enable driving directions, to notify that urgent care that I'm on my way, to allow me to notify the urgent care when I'm in my in the parking lot of the urgent care, to check me in automatically, and to automatically then bring up for my clinician the relevant aspects of not only my medical record, but my presenting symptoms, essentially why I'm there, and then direct me to the room that I'll be seen in. That's an example of getting me from the early stages of the interface to actual problem resolution in a way that doesn't have a dead end. And I would say, again, to this same point, this is one of the things that we're starting to think about in the vaccine space. So we've done a lot of work around scheduling, all of which in our organization is done either by phone or online. And of course, as again, I think all of us know, there are significant portions of even our membership base that either don't have access, good internet, broadband access, and can't go online. They may not have a smartphone, but even more importantly, they have dimensions of their lives that really prevent them from scheduling an appointment for a vaccine, a first dose, much less a second dose that has to be timed properly. They don't have the ability to do this weeks in advance because they have unstable schedules. Roughly 17% of workers of color, for example, are working multiple shift jobs where they may not know their schedule even tomorrow. Or if they do know their schedule, they show up at work today, they're offered overtime, pick up an extra shift tomorrow, and suddenly everything changes. So as we've studied this problem and thinking about we don't want a dead end in the system, one of the things that we've discovered is that for those who have non-stable schedules, the single most important design solution to not only get people scheduled, but to have them follow through, show up at their appointment, and then show up for a second dose, is the ability to schedule by text message. And not only to schedule, but to cancel an appointment. The ability to do both of those things where I don't have to interface with a human, right? I don't have to say, gosh, my schedule has changed. I feel guilty because like I'm a hard worker. I feel guilty about the fact that I have to cancel last minute. The ability to do that by text message, we have some data to demonstrate we get significant compliance, significantly higher compliance in those instances. So it's kind of an example of how we're applying that thinking in this particular space. I'd say that the third lesson that we sort of have learned from the field is the importance of platform thinking. And for us, again, I think like many organizations, a platform is a piece of proprietary technology or a process or a service that conveys bidirectional value. And the iPhone, I think, is a pretty traditional and well understood example of a platform that conveys bidirectional value, both to Apple and a whole ecosystem of partners, and obviously to us as consumers. So one of the projects that we've been working on now for a number of years, but that has been accelerated in COVID times, is to really completely reimagine what care and service is like in the home for our members. So this isn't sort of the traditional home care interface, but it really is sort of a different way of delivering service in a way that brings together sort of seamlessly what patients and their caregivers experience, a rapidly deployable home care team, and a command center, which is doing everything from monitoring patients remotely to managing the logistics of how it is that care teams go from place to place. And I guess the real point that I would make here relative to platform thinking is this. I think in our organizations, probably like many, if you were to look at the types of services that we provide in the home, the way that we had thought about them historically was, well, we're going to stand up a home health business. And then we have a DME business that's separate. And then we have a cardiac rehab business that's separate from that. And then we have a home monitoring business that sort of operates over here to the side. The ability to unify all of that, which as a consumer, as a patient or a caregiver, is how I think about these things anyway, right? I don't think that my home health nurse should be different than my cardiac rehab nurse, and so forth. The ability to do that using platform technology allows that experience to be far more seamless than it would be otherwise. So we're really looking at the interoperability of service and experience and tying those together through technology. So that's sort of platform thinking at work. The fourth key lesson for us is the idea of making the invisible visible. And there's a lot of really great thinking on this. There's a physicist, Safi Pakal, who, if you haven't read his work, is pretty incredible. He wrote this book called Loon Shots, which is, he really speaks to how it is that ideas and innovation take hold, particularly in organizations. And so he tells this story about all of these sort of innovations that we've maybe had some experience with, from entertainment, for example, James Bond and the James Bond franchise, or My Big Fat Greek Wedding, or Seinfeld, or even in a technology sense, radar or digital image capture. And what he talks about here is that in each of the organizations where these innovations came from, the innovation or idea came up, it was introduced in the organization in some instances decades before the organization was ready to accept it. Radar, for example, was discovered by the US Navy 20 years before it was actually deployed in World War II. And the point that he makes, I think, is this. We've all heard this. I think it's the Cotter notion that culture eats strategy. Safi's argument is that both structure and incentive in organization will eat both culture and strategy. That in our organizations, we are organized and incentivized to maintain the status quo, and that status quo effectively runs counter to new ideas coming to fruition. I think perhaps a better example for us in healthcare is this idea of slow ideas, which Dr. Atul Gawande proposed, I think now close to a decade ago, in a New Yorker article. And you probably know the story that he frames up, I think, really well, of anesthesia and antiseptic. Anesthesia, which was introduced, I think, in the late 1860s, and over the course of really a number of months, not only was the first anesthesia actually deployed in a Boston-based hospital, but within a number of months, there was a publication, and you started to see then, within 5 or 6 months, all over Europe, anesthesia ether specifically was being more readily used. Within a matter of 7 years, you could see ether being used in surgical theaters around the entire world, as opposed to antiseptic, which, when introduced also in the late 1800s, took almost a generation before it was widely deployed. Very consistent with the sort of 17 years from bench to bedside rule of thumb that we still see today, that translation of research to actual practice. One of Atul's sort of, I think, hypotheses here is that some ideas don't catch on because they are less visible. There is a gap between application and effect. Anesthesia, which you could apply and see the effect of right away, very different than antiseptic. It's probably more complicated than that, and I think Dr. Gawande's position is certainly consistent, but we spend a lot of time in our practice thinking about how we can take things that don't have immediate effect, that feel sort of nebulous and vague and trying to make them concrete using a lot of different techniques. And I would just say that, you know, again, apropos to the moment, when you think about kind of the experience over the last year with SARS CoV-2, it largely follows this sort of thinking, particularly for those in the general public who didn't have firsthand experience with COVID-19, who weren't treating people or didn't know somebody who had this particular virus. What we saw was this gap between what you hear in the media or you saw in terms of infection rate data when somebody would have symptoms, when somebody might be hospitalized, or what increases in hospitalization rates would look like, and then ultimately death rates. So the gap between and the lack of immediacy between the infection itself and the really sort of deleterious effect of that felt invisible to people. And so I think one of the jobs in terms of how we communicate and how we tell stories is to make those things that are invisible visible. Skip this and just say, again, in our practice, we do a lot of work in terms of how it is that we tell stories. We try and do that in ways that are immersive. You think about, for example, the business justification for investing in housing, why addressing or tackling the issue of putting a roof over somebody's head is critical to their health, why it makes sense in terms of ER utilization. Getting people to take that very vague concept and turn it into action requires immersing them in the experience of homelessness. And so we will create these immersive environments to tell stories so they can feel that firsthand and then hear why it is that it makes sense for us as a business to invest. We do a lot of work in prototyping products. This is the home prevention kit as an example that we designed early on in the pandemic. So we want to show people in ways that are very concrete how it is that we think about framing up and communicating information. We prototype experiences by showing what a future state would look like in ways that are very human and tangible, how it is that the built environment, technology, and service delivery would fundamentally play out before we ever invest in actually making those experiences and bringing them to life. And certainly, as you all would be familiar with in a digital environment, using wireframes and digital prototypes is another great way to do this. And then just very quickly, sort of the last point that I'll make in terms of lessons is kind of two sides of the same coin. And that is for us, this idea of wandering and the importance of wandering in innovation, and then funding. And so there's this combination of time and how it is that we ultimately get things to scale. And again, to use an Ed Catmull quote here, if you're familiar with sort of the Pixar philosophy, they talk about this idea of the ugly baby, right? That in the early days, every film or every story that they tell is an ugly baby. And really, you have to give enough time for that baby to grow up to understand whether it really is an ugly baby and it's not going to materialize into anything, or if ultimately it goes from, as Catmull says in this quote, from suck to not suck over time. But that requires a lot of investment and a lot of patience. Also very consistent with the Amazon culture and Bezos, who talks about this idea of wandering. That particularly in innovation, we need time to explore and to experience and to go into work without any notion that that work will produce results. And so this is one of the things in our organization that we've had to help, in particular, our senior leaders understand as it pertains to the competencies of leading design-based innovation. The other component to that, I'll just say, is then how we fund things. And there are sort of two pieces. The first, as the slide points out, we sort of make this point that we try really hard not to introduce financial metrics into the work too early on, because really innovation can be crushed under the weight of those metrics if we introduce them too early. Instead, we have this notion, what we call phase appropriate metrics, which is to say that any innovation work, any idea is going to evolve in its maturity through a set of predictable phases. And at each of those stage gates, the level of rigor, both in terms of metrics and kind of the financial commitment, those things can get more rigorous as we go, but we have to apply the right level of rigor to the phase that we happen to be in. And so we go from sort of a back of the napkin value sketch all the way to what we sometimes call a skeleton P&L to then a case for action, which is more of a traditional business case. I've also mentioned this idea of kind of the phases. For us, the phases represent a portfolio. And that is a portfolio of where projects are in their maturity. So we have this balance of early phase innovation and phases which are being pushed through the operational channels of the organization, being deployed at scale. We have different levels of risk, different levels of investment, different levels of ambition. And it's sort of that combination of things, the phases, the levels of ambition, finances, et cetera, that make up the portfolio for us. You know, this is sort of a play out of the venture capitalist playbook. Most VC folks will tell you that 75% of innovations never bear fruit. They never make it to market. So, you know, we know that, you know, we're at best going to hit 250, as it were. And so making sure that we're managing that risk through a portfolio mentality is pretty important lesson. So apologies that took a little bit longer, but it looks like we still have a few minutes for questions, and happy to take any that folks have.
Thank you, David, and all kind of well managing, again, a fire alarm. So kudos to you.
Thank you.
I think this is a first for CDH. We've had all kinds of stuff, but this is, yeah.
Leave it to the innovation person to be the first, you know.
Exactly. That was lovely. Thank you. I have to say, I just want to kind of give a shout out to your slides in particular. They were absolutely beautiful. So nicely designed. I did get a couple of private questions in the chat. I know that we're recording this, but some folks were wondering whether or not you'd be willing to share slides either as a PDF or something like that, as long as they agree to keep them within themselves.
Yeah, absolutely. We'll get a PDF framed up and we'll send it over to you.
Thank you. Natalie, you had a question in the chat. I'll give you a chance if you want to ask it yourself. You're welcome to. Otherwise, I can ask for you.
Yeah, I don't mind asking. So it seems like a lot of this type of thinking is predicated on the consumer having some sort of technology. How have you / Kaiser Permanente overcome the barrier of lack of access to technology? For example, there are still vulnerable populations who don't have cell phones, let alone a smartphone.
Yeah, it's a great question and a really important call out. And I would say we are very much in the early days of addressing that issue. This idea of the digital divide that I mentioned, I think very early on, is a project that we're just starting to take up. I would say that the way that we're thinking about it, though, as you would expect, is as holistic as we possibly can. I think that as we've talked to some folks, it's very easy to jump to the conclusion that, well, if we just have broadband or if we just had devices, then we're going to solve that problem of access. And the reality is that the problem is far more complex than that. Digital literacy, as an example, at multiple ends of the age and socioeconomic spectrum is a clear issue. Public utilities, having infrastructure, have we pulled fiber optic line and dart cable to the right places? Can we transmit Wi-Fi effectively? Even how it is that we measure whether or not people have good broadband access is highly problematic. And some, as we started to study this, you'll see some organizations, like if you take two organizations and say, like, what really is digital access like in the US? There are these wildly different perspectives on that, like that vary by hundreds of millions of people. And again, this is no surprise to you all who work in this space. It has to do with how it is that we measure that. What really qualifies as broadband level speed? No consensus. if one household in a census tract has a certain level of speed, then it is assumed that all in that census tract have the same level of access. Not a great assumption. So, and again, in COVID times, I think, we saw, for example, amongst a lot of the different school districts that Kaiser Permanente has as clients, just because we gave kiddos Chromebooks and a Wi-Fi enabled hotspot did not mean that they were actually able to access content, that they were actually able to stream video in real time. And suddenly there was this enormous learning curve. So those are all of the things that we're going to have to solve for in this space if we actually want to close that digital divide. And it's going to be pretty critical. I mean, our organization, we went from a pretty high degree of telehealth deployment before COVID to now 85 to 90% of every clinical interaction in our system is done digitally first. Well, guess what? We have large swaths of people who are going to be left behind if a lot of that sticks. Last point that I'll just make about this from a policy perspective, because I think this is really important too. We're starting to do, I think, advocacy around the Biden-Harris administration's infrastructure bill. So when you look at, and of course this is going to go through all kinds of evolutions and changes as it progresses, but right now the focus for broadband in that infrastructure bill is for rural communities. And that is absolutely critical. We know that broadband access can be transformational in rural communities, particularly as it relates to telehealth. But I will tell you, you do not have to go far outside of an urban core or even within urban neighborhoods to find places that do not have access to broadband. And so we're really going to have to advocate that this is not just a rural health issue. This is really ubiquitous. So it's a great question and sort of a long answer. I wish that I had like a 5-step approach. Here are our 5 lessons to closing the digital divide. But those are the things that we're thinking about.
Thank you, David. And I think I'll just add on there, Natalie, kind of just that David specifically mentioned the text messaging, which I think is really an important aspect. So we find in our work that 95% of Americans have some sort of cell phone. As you go younger, they're more likely to have a smartphone, may or may not have Wi-Fi access, but pretty much everybody has access to texting, which I think is just a great example, David, of how you guys address that with the vaccine appointments, was going for the least common denominator, the thing that doesn't require 5G service and that we know that everyone has access to.
Well, and I'll just say too, it's a great example, I think, also that illustrates this point of the socio-technical system, right? The lack of broadband, the relatively ubiquitous deployment of a cell phone, right? That's the commercial technical side of the problem. But then there's also this human reason, right? I have guilt if I don't show up for an appointment. And so the ability to do that asynchronously by text, that's the human factor, the psychology that ultimately induces the behavior. So it's to your point, Megan, it's a great way of, how we think about both sides.
Yeah, I love that. I love that. And I think it's really important for all of us to keep in mind, because I think when we're developing things, we often think purely in terms of the patient or purely in terms of the system or purely in terms of the provider, right? Which all intersects together.
Right.
Jeff, I see that you have a great question in the chat. Do you want to unmute and ask?
Yeah, sure. This is kind of actually coming off what you just mentioned, but thanks. Hi, David. Thanks for the talk and especially the example of changes. It seems like the examples you shared move towards more of a user-centered design, whereas things are traditionally top-down, and specifically design involving things like iterating on prototypes, involving users throughout the process, empowering end users to make decisions, where like end users are patients and staff. And I was wondering, like, do you ever encounter sort of resistance, or what are your main arguments to convince people that this is actually the right approach, when I imagine healthcare is traditionally made like top down by experts in advance, like regulations and committees and stuff like that?
There is never any resistance ever, not even a little bit. It is so easy. I mean, yes, the resistance. And you know, I can point to a number of different things. So first I'll say the notion of resistance is one of the reasons why we use this human need, business need kind of duality. Because depending on audience, I can frame the argument tailored to the mindset of the particular stakeholder group. So sometimes I'm making an argument which is business first, right? We have a viable solution, one that's economically viable and scalable, that's going to solve a fundamental business problem. And oh, by the way, we have a pretty good sense that our members are going to use the thing. Or alternatively, I might flip that and actually use first-person narrative that is derived from our human-centered design, our deep sort of ethnographic inquiry, where people are telling their stories, where they're talking about the places in which some experience or some service or some technology has broken down for them. You know, and one of the things that we hear from our providers all the time is that this ability to actually hear from members directly is something that they don't get to do in the confines of a 15 to 20 minute visit where they're trying to get to problem resolution, right? So the ability to sort of hear, okay, well, this is what was really hard for my patient to navigate, to actually get to me, right? Where the magic happens. Well, now I can support the thing that you're trying to solve for, right? So it's how we tell stories. It's how we make the invisible more visible. It's how we frame the argument, both in terms of the human need and the business need. And all of those things help with the resistance. There is no magic bullet. It is also a lot about just persistence. We use this phrase, persistently optimistic, as kind of how it is that we want to show up in the organization. And that is to know we're just going to have to keep at it. And it may take years, in fact, and we may be in the jaws of defeat over and over and over again, but we've got to be optimistic that we're going to pull it out. And, you know, so that trait, that mindset is actually also critical, at least for us as humans engaging with resistance.
Right. One thing I got out of that is actually, it seems like you start the understanding user process even before talking to the experts, and then you come in with the stories. So it seems like you have that in mind as part of the process, which is great.
Yeah, you know, we do both in parallel. It turns out we actually do primary research with end users, and we do secondary research with experts and in the literature in parallel. And the reason that we do that is to find gaps, right? We work with scientists, and we believe in a science-first approach to the work. So we will come in with our experts and say, here are the things that we think the science says. Do you agree? Here are the gaps that we're perceiving. Do you agree? Here's how the primary research that we've done sheds some light on how we might close those gaps. And so it's you know, we're trying to operate again in multiple domains simultaneously. And so we got to do both at the same time.
Thank you. I know we're at time. I know that there are a bunch more questions in the chat. I will kind of encourage folks, David, I want to be respectful of your time. I know that it's the top of the hour. If you have a little time and people want to stay on, you're welcome to. But I want to take the opportunity to thank you. I think kind of thinking through, like I said, this intersection between the system and the person is so critical. And you really outlined a different way of approaching design thinking, kind of outside of the trendy, let's get together in a room with a bunch of Post-it notes. A more kind of technical and theoretical approach that I hope will serve all of us well as we move forwards in trying to create our next version of transformational interventions. I frequently say that to me, technology is a means, not an end. And if we don't create our programs with the end user in mind, you know, we failed from the get-go. So thank you for joining us, and I hope that it appears that your house has not burned down, which I'm quite happy about as well.
So far, so good.
Yeah,
that's
awesome.
The big bonus for the day. So yes, thank you very much. It's been a pleasure spending some time with all of you. Thank you for the time and the thoughtful questions. I'll get a PDF over, and then I don't know, Justin, maybe if there are specific questions that I haven't answered in the chat, if you'd want to email those to me, I'm happy to respond that way to folks and just give a little insight, or if there are other resources I can point folks to. I'm
Thanks.
happy
That would
to
be
work with that.
terrific. Really appreciate that, David.
Sounds good.
All right.
Thank
We'll
you
talk
all.
soon. Thank
Sounds
you,
good.
everybody.
Thank you guys.
Bye, everyone.